Welcome to the Funnel Effect, Asian Pacific Society of Cardiology consensus statements on the use of transcatheter edge-to-edge repair in the treatment of tricuspid and mitral regurgitation. Kung Kyung Ye, Dave W. Mayumo, Jianan Wang, Shunsuke Kubo, Shisian Sung, Saya Satish, Krisada Mimuk, Duyun Kang, Sihui Win, Alex Priwai, Mintaro Hayashida, Philip Y.K. Pang, Shang Bin Pan, Darren L. Walters, Gregory Michael Scalia, Youngsun Kim, Michael Kangyan Lee, Praveen Chandra, Louis Teo, Guangguan Song, Tigu Santoso, Chen Mao, Yan Wang, Makoto Amaki, Yohei Ono, Masaki Izumo, Masahiko Asami, Mike Saji, Amin Arif Nuruddin, Kongwu Park, Kwango Chongyin, Kritvikram Durung Pizitkul, Ninyon Wang, Ivandi Tukujoro, Azmi Modgazi, Kenny YK Sin, Martin Ang, Ket Chakyuso, Chongshi Simon Lam, Angus Xing Feng Shui, Gilbert H. L. Tang, Jack Wei Chetan, and Takashi Matsumoto. Published in JCC Asia 2026.
That is quite the list of names, right?
Yeah, it really is. And I know for you listening, sitting through 43 distinct names read aloud at the top of the show demands a little bit of patience.
A lot of patience, actually.
Yeah, exactly. But it also demands that we ask a really crucial question. Like, why did 43 of the most brilliant cardiovascular minds across the entire Asia-Pacific region mobilized to write this exact document?
Right, because they didn't just do this for fun. They mobilized because the Asia-Pacific region is facing what you could call a uniquely devastating demographic storm.
A storm of heart disease, essentially.
Exactly. So for the next hour in this deep dive, our mission is to basically unpack this massive 2026 consensus statement.
We want to translate these highly dense, super intricate cardiology guidelines into a clear roadmap for you.
Right. We're going to explore the mechanics of how doctors are fixing severely leaky heart valves without resorting to the massive trauma of open heart surgery.
Using an advanced technology called transcatheter edge-to-edge repair.
Or TEER, yeah. So this isn't just another medical paper. It is legitimately a regional survival guide.
I really want to focus on that regional aspect first.
Yeah.
Because the Asia-Pacific, it isn't just one big homogeneous healthcare system, right?
Oh, not at all. Not even close.
Yeah, you have these hyper-modern, heavily funded academic medical centers in places like Tokyo or Singapore.
Right, with all the latest tech.
But then you also have these sprawling, resource-strained rural clinics in other parts of the continent. But the baseline disease burden, this sort of silent explosion of heart valve disease, is hitting everywhere.
It's hitting everywhere simultaneously.
So why is this happening right now?
Well, it really comes down to the compounding effect of aging and metabolic disease. As the population across the Asia-Pacific region ages at this unprecedented rate, you see a natural biological increase in degenerative valve disease.
Which is basically just wear and tear, right?
Yeah, exactly.
Yeah.
Simply the physical wear and tear on the heart's structures over decades of pumping. But the issue is, you don't just have an older population.
Right.
You have an older population that is simultaneously experiencing skyrocketing rates of atrial fibrillation, chronic hypertension, and just, complex metabolic comorbidities.
So it's like a perfect storm of pressure on the heart.
It is. Each of these conditions acts as this brutal stress test on the architecture of the heart. And when it's left untreated, the endpoint for these patients is just relentless.
Yeah. It's pretty grim. We are talking about a continuous loop of heart failure hospitalizations, right?
Right. A complete erosion of their quality of life and ultimately premature death.
To understand how we prevent that death, we have to understand the mechanical failure happening inside the chest.
The literal plumbing of it.
Exactly. We are focusing on two specific doorways today: the mitral valve on the left side of the heart and the tricuspid valve on the right.
The two main entryways, essentially.
Right. And in the past, people often compared these valves to swinging doors in a house. But I think that analogy is far too simple for what is actually happening.
I agree. It doesn't capture the pressure.
Yeah, it's more accurate to think of these valves like a precisely engineered suspension bridge. The valve leaflets are the bridge deck, and they snap shut to hold back immense fluid pressure.
Right, the blood trying to push backward.
Exactly. And they are held in place by these tough, fibrous strings called cordae tendineae, which act just like the steel suspension cables on a bridge.
That is a much, much more accurate physiological model, because when those suspension cables stretch out from heart failure, or they snap entirely from degenerative wear and tear, the bridge deck just flails.
It just swings wildly.
Yeah. The leaflets fail to meet in the middle. They lose what we call coaptation.
Coaptation, okay.
Right. And when that coaptation gap forms, the immense pressure of the heart squeezing forces blood backward through that gap.
And that backward flow is the regurgitation.
Exactly. Imagine your heart is pumping, But instead of the blood rushing forward to oxygenate your brain and body, a massive volume of it violently surges backward.
That sounds terrifying.
It is. It pools in your liver, it backs up into your kidneys, your legs swell, your abdomen fills with fluid, and you find yourself gasping for air, just trying to, tie your shoes.
This is the brutal physical reality of severe valvular regurgitation.
It's a miserable way to live.
Historically, if your suspension bridge was collapsing like that, the only answer was to saw the chest open.
Right, sternotomy.
Yeah. You put the patient on a bypass machine, stop the heart entirely, and surgically rebuild or replace the valve.
Which works beautifully for a lot of people.
But the patients we were talking about today, the elderly, the frail, those with severe kidney or lung disease,
Yeah.
they literally cannot survive that level of surgical trauma.
They would die on the table or shortly after.
Right. And that is exactly where TEER comes in. Can you just walk us through the physical mechanics of this transcatheter approach?
Sure. So instead of opening the chest, an interventional cardiologist makes a really small puncture in the femoral vein right down in the groin.
Just a little needle poke.
Exactly. And they thread this highly sophisticated steerable catheter all the way up through the body into the heart.
While the heart is still beating.
Oh, yeah, fully beating. And through that catheter, they deliver a tiny mechanical clip. So under continuous real-time ultrasound guidance, they navigate this little clip directly over the failing valve leaflets. They open these microscopic mechanical arms, grasp the flailing edges of the leaflets, and just clip them securely together.
So they basically pinch the bridge deck back together.
Exactly. By pinning the center of the leaflets together, you create a double orifice valve. You bridge the gap, significantly reducing that backward flow of blood.
It really sounds like science fiction.
It does, but it is the current standard of care for high-risk patients.
However, deciding exactly who gets this high-tech clip and exactly when they get it is incredibly complicated.
Very.
Which brings us to how this 43-member panel actually built this consensus. Because they didn't just sit in a room and guess, right?
No. They relied on something called the GRADE framework to evaluate all the clinical evidence.
We see a lot of medical studies thrown around in the news.
Yeah.
But for you listening, it's important to know not all evidence is created equal. So how does this GRADE system force doctors to be honest about their data?
Well, the GRADE framework is a rigorous, standardized methodology. It's really designed to strip the bias and the wishful thinking out of guideline writing.
Okay, how does it do that?
It forces the authors to assign a specific level of confidence to every single piece of evidence. They break it down into 4 strict tiers. The first is high confidence.
High confidence meaning what, exactly?
This means the panel is virtually certain that the true clinical effect of the TEER procedure is identical to the estimated effect seen in the massive clinical trials.
Okay, so if the trial says the clip reduces hospitalizations by 40%, high confidence means you can bank on that exact number in the real world.
Correct. You can take it to the bank. The next tier down is moderate confidence.
And that means?
Here, the panel believes the true effect is probably close to the trial estimates, but, they acknowledge there is a real possibility it could be substantially different once it's actually applied to a broader, messier, real-world population.
Right, because clinical trials are very controlled.
Exactly. Then you hit low confidence, meaning the evidence base has serious limitations.
Like small sample sizes.
Yeah, maybe the trials were small or the data was conflicting across different studies, so the true effect might be markedly different.
Got it. And the last one?
Very low confidence, which just means any estimate of effect is highly uncertain. We really don't know for sure.
By stamping these grades onto their recommendations, the panel provides this incredibly transparent map of where the medical science is rock solid and where it is still kind of evolving.
It's extremely helpful for practicing doctors.
And the timeline of how they built this is fascinating, too. They held these intensive meetings in February and May of 2025.
Right.
Following that, they instituted this brutal electronic voting system. A statement didn't just need a simple majority to pass.
No, a simple majority wouldn't cut it.
The panel had to keep debating, revising, and voting until a minimum of 80% of the experts voted either agree or neutral on every single clinical rule.
80% is a very high bar for a room full of doctors.
I can imagine. And that final consensus was locked in during August of 2025. But here's the really critical part.
Right, the cutoff.
Yeah. Because they locked the doors in August 2025, they explicitly admitted they could not include the massive European guidelines from the ESC and EACTS, which were published literally just days later. on August 29th, 2025.
Which is wild timing.
It is. Some people listening might view that as a flaw, right?
No.
Just assuming the Asia-Pacific document was instantly outdated the second it was published.
Yeah, I've heard that criticism. But in the realm of clinical science, it is actually a profound demonstration of procedural integrity.
How so?
By refusing to retroactively shoehorn in European data that they hadn't subjected to their own rigorous, months-long debate and voting process, they maintained the purity of their consensus.
I see. They didn't cheat the system.
Exactly. It draws a clear line in the sand for the reader. It tells the clinician exactly what evidence was weighed, allowing that doctor to independently evaluate this regional consensus against any newer data that emerges globally.
That makes total sense. So let's move from the methodology to the actual anatomy. The consensus tackles the heart by dividing it into the right side and the left side.
A very logical split.
We're going to begin our journey on the right side, focusing on the tricuspid valve. Now, for a long time in cardiology, the tricuspid valve was essentially called the forgotten valve, right?
It really was the neglected stepchild of the heart.
Doctors were so focused on the high-pressure left side of the heart that the tricuspid was often just ignored until the patient was practically in end-stage failure.
Yeah, we just gave them diuretics and hoped for the best.
But reading through the clinical rules for the right side in this document, it is really clear that philosophy has completely flipped.
The philosophical shift is undeniable. It's a totally new era.
What's the biggest change?
The most glaring example is how we even classify the severity of the disease. Historically, cardiologists relied on a 4-stage grading system established by the American Society of Echocardiography.
And that was none or trace, mild, moderate, and severe, right?
Right, the classic 4. But this panel unanimously voted to discard that old framework for patients being evaluated for transcatheter interventions.
They threw it out.
Totally. They adopted a new, highly specific 5-grade system: mild, moderate, severe, massive, and torrential.
Okay, I have to pause here because this sounds incredibly dramatic.
It does sound like a weather forecast.
Exactly. Severe, massive, torrential. From a layman's perspective, or even a patient's perspective, do we really need 3 different adjectives for terrible?
Right.
If my basement is flooding, I don't care if the plumber calls it severe or torrential. I just need it fixed. Does changing the vocabulary actually change the medical treatment?
It absolutely alters the treatment, fundamentally, because it redefines the hemodynamics of the right ventricle.
Break that down for me.
Under the old system, a patient with a significant tricuspid leak was labeled severe. But another patient, one whose valve was so utterly destroyed that the blood was rushing backward with catastrophic volume, was also just labeled severe.
They're in the same bucket.
Right. The problem is, those 2 patients are experiencing vastly different physiological loads. The physical pressure destroying the right ventricle, the liver, and the kidneys is categorically different.
So if you lump them together in a clinical trial, you basically ruin your data.
Precisely. You completely blur the lines. If you perform a TEER procedure on a patient with a torrential leak, and the clip successfully reduces that backward flow down to just a severe leak.
The old grading system would label that a clinical failure.
Exactly, because the patient went from severe to severe on paper, but biologically, that reduction from torrential to severe relieves an immense amount of pressure off the right side of the heart.
So the patient actually feels better.
The patient will feel significantly better. Their liver congestion will improve, and they can breathe again. By introducing massive and torrential, the panel allows clinicians to accurately risk stratify patients and measure the true, nuanced efficacy of these transcatheter devices.
Okay, that sets the stage perfectly for the specific clinical criteria. Who actually qualifies for a tricuspid TEER or T-TEER procedure?
The guidelines are incredibly strict here.
Yeah, a patient must have symptomatic, severe, massive, or torrential tricuspid regurgitation.
Right, so grade 3, 4, or 5.
They also have to be classified as New York Heart Association Class 2 to IVA. For context, NYHA Class 2 means you have slight limitations like you get winded climbing stairs.
Very common.
But Class IVA means you are exhausted and gasping for breath even at rest, sitting in a chair.
It's a huge spectrum.
Furthermore, their pulmonary artery systolic pressure, or PASP, must be under 70 millimeters of mercury. And above all else, this is the big one, they must already be on optimized medical therapy.
The medical therapy requirement is the absolute bedrock of this entire consensus. You never, ever rush a patient to a catheterization lab to implant permanent metal hardware into their heart until you have utterly exhausted what modern pharmacology can achieve.
Needs first, always.
Always. And this rigorous patient selection criteria is directly anchored by the foundational data from the Triluminate pivotal study.
Let's dig into Triluminate. This is a prospective randomized trial, right?
It was a very big deal in the cardiology world.
They took 350 patients who met these exact criteria: severe symptomatic TR, pulmonary pressures under 70, and fully optimized on their heart failure medication.
Yep.
And they split them into two groups. Half received the TriClip transcatheter device, and the other half simply continued with their medical therapy alone.
The control group.
Right. What was the physical and clinical difference between those two groups?
The clinical divergence between the two groups was striking. The Triluminate data demonstrated that the T-tier procedure with the TriClip safely and significantly decreased the severity of the tricuspid regurgitation.
The plumbing was fixed.
The plumbing was improved, yes. But from a patient-centric view, the most crucial finding was the dramatic improvement in quality of life.
How do they measure that?
We are talking about objective metrics like the Kansas City Cardiomyopathy Questionnaire scores.
Oh, where patients report if they can do daily tasks.
Exactly, where patients reported vastly improved physical capabilities. Furthermore, long-term follow-up analyses revealed that the patients who received the clip experienced a reduction in recurrent heart failure hospitalizations.
They stayed out of the hospital.
Right. They had sustainable long-term symptom relief and highly favorable survival rates, all with incredibly low rates of ever needing another intervention on that valve.
It is definitely worth noting that while the TriClip has the massive randomized data behind it right now, the device landscape is expanding.
Oh, rapidly.
Yeah, the consensus document explicitly highlights the Pascal device, noting that emerging non-randomized data is showing excellent promise, and we are eagerly awaiting the results of their own randomized controlled trials.
It proves that the biomedical engineering in this space is just iterating so fast.
But regardless of which clip you use, making the decision to deploy it isn't left up to one lone interventional cardiologist.
No, definitely not a solo mission.
The guidelines mandate the use of a multidisciplinary heart team.
The heart team is non-negotiable. The complexity of transcatheter structural interventions requires a synthesis of highly specialized viewpoints.
Who is on this team?
The consensus dictates that this team must include, at a minimum, a cardiothoracic surgeon, an interventional cardiologist, an echocardiologist who specializes in reading the complex imaging, and a heart failure specialist.
So 4 different specialties.
At least. You need the surgeon to evaluate the inherent surgical risk. You need the heart failure specialist to guarantee the medications are truly maximized. You need the imaging specialist to map the millimeter by millimeter anatomy.
And the interventionalist to actually do it.
Right. Only through this collective analysis can you ensure the procedure is mechanically feasible and align with the patient's overall goals of care.
I really want to focus on that imaging aspect because seeing the problem is obviously the only way to fix it. How do we accurately diagnose the root cause of the leak?
It's all about the echoes.
But the guidelines also point to right heart catheterization as an option when the non-invasive ultrasound findings are confusing or discordant.
Yeah, that happens sometimes.
Why is an invasive procedure literally threading a catheter through the body to measure pressure necessary when we have advanced ultrasounds?
Well, while echocardiography is the absolute frontline tool, it ultimately relies on acoustic estimates to calculate pressure.
It's making an educated guess based on sound waves.
Exactly. When a patient's clinical presentation doesn't match the ultrasound estimates, you need definitive, absolute measurements. A right heart cath allows the physician to directly measure the pulmonary artery pressures and calculate the pulmonary vascular resistance.
But you get the hard numbers.
Undeniable, hard data. It distinguishes whether the tricuspid leak is being driven purely by left-sided heart failure backing up into the lungs, or if there is primary pulmonary hypertension driving the right-sided collapse.
Oh, so it tells you where the problem's actually starting.
Right. You cannot effectively treat the valve until you understand the exact hemodynamic pressures pushing against it.
Which brings us to the imaging showdown. Transthoracic echocardiography versus transesophageal echocardiography. TTE versus TOE.
The classic battle.
A transthoracic echo is the classic ultrasound wand rubbed across the patient's chest. The consensus states this is mandatory for the initial assessment of severity.
Yes, step 1.
And it must be performed when the patient is in a euvolemic state, meaning their fluid levels are perfectly balanced by their medications. But when it actually comes time to evaluate a patient for the mechanical clip, The guidelines mandate the use of the TOE, the transesophageal echo.
They absolutely mandate it.
Why must the patient swallow a camera?
It comes down to anatomical proximity and acoustic windows. When you use a transthoracic echo on the outside of the chest, the high-frequency sound waves have to penetrate through the rib cage, muscle layers, and air-filled lung tissue before they ever reach the heart.
So it's distorted.
It is acoustically analogous to trying to observe fine details through a thick, frosted pane of glass. However, the esophagus lies directly behind the left atrium of the heart,
Oh, it's right next door.
literally leaning against it. By advancing the ultrasound probe down the esophagus, you completely bypass the chest wall and the lungs. You place the transducer millimeters away from the valves.
Wow, so the picture must be incredible.
It provides ultra-high-resolution, real-time 3D reconstruction of the anatomy. The interventionalist requires this pristine roadmap to evaluate the leaflet morphology, measure the precise coaptation gaps, and safely guide the clip into place during the procedure.
This high-resolution imaging is exactly what populates Table 1 of the consensus document. Table 1 is essentially an anatomical scorecard for tricuspid tear.
A pass-fail grade, essentially.
They categorize a patient's inner anatomy into favorable, complex, and unfavorable criteria. And the most critical metric on this scorecard is the coaptation gap.
The literal physical distance between the edges of those flailing suspension bridge decks.
Right, so what are the numbers here?
In structural cardiology, millimeters dictate the entire procedural strategy. The consensus defines a favorable coaptation gap as being 7 millimeters or less.
7 millimeters is pretty small.
It is, but at this distance, the mechanical arms of the transcatheter clip can easily reach, grasp, and securely bind the leaflets together.
What if it's wider?
If the gap widens to between 7 and 10 millimeters, the anatomy is downgraded to complex. The procedure is still viable, but it demands an exceptionally skilled operator, advanced steering techniques, and potentially the deployment of multiple clips to slowly zipper the gap closed.
Like a literal zipper.
Yeah, step by step.
But once that gap exceeds 10 millimeters, the panel labels the anatomy unfavorable.
Yes. Beyond 10 millimeters, the leaflets are simply too far apart. Attempting to force the mechanical arms to bridge that massive divide places extreme, unnatural tension on the fragile leaflet tissue,
It would pull too tight.
drastically increasing the risk that the rip will simply tear the tissue off the valve, resulting in catastrophic failure.
What I find really fascinating here is that the text reveals a fierce underlying debate among the panel members regarding these exact measurements.
Oh, there was definitely a fight over this.
A vocal minority of the 43 experts argued that 10 millimeters was too generous. They wanted the unfavorable cutoff lowered to greater than 8.5 millimeters, shrinking the complex window to a tiny margin between 7 and 8.5 millimeters.
That is a razor-thin margin.
It really is a brilliant reminder that these guidelines are not handed down from a mountain. They are living documents forged by experts passionately arguing over 1.5 millimeters of tissue.
That debate reflects the bleeding edge of clinical reality. The experts pushing for the stricter 8.5 millimeter cutoff are likely drawing from visceral, real-world experiences where stretching a clip across a 9 millimeter gap resulted in suboptimal outcomes or high tissue tension.
I've seen it fail.
Exactly. The consensus captures that nuance beautifully.
Beyond the gap itself, the scorecard also evaluates the location of the regurgitant jet. An anteroseptal jet location is considered favorable, whereas an anteroposterior jet location is deemed unfavorable.
Right. Geography matters.
Why does the geographical location of the leak within the valve matter so much to the clip?
Well, the tricuspid valve is a highly complex three-dimensional structure. While it typically has 3 distinct leaflets, the anterior, posterior, and septal, the variations are wild. Some patients have 2, some have 4.
It's not standard.
Not at all. An anteroseptal jet is easier to target because the trajectory of the delivery catheter as it enters the right atrium aligns naturally with that specific commissure.
It's a straight shot.
Right. Reaching an anteroposterior jet, however, requires extreme, complex torquing and bending of the catheter system within the beating heart.
You have to bend the catheter back on itself.
Essentially, yes, which significantly increases the technical difficulty and the risk of damaging surrounding structures.
And we cannot ignore the role of other hardware in the heart. Table 1 specifically addresses patients who have a CIE, a cardiac implantable electronic device, such as pacemaker.
Very common in this age group.
Many of these elderly patients already have pacemaker wires threaded through their right atrium and directly through the tricuspid valve into the right ventricle. How does a pacemaker wire complicate the placement of a transcatheter clip?
The physical presence of a pacemaker lead traversing the tricuspid valve is one of the most challenging variables in T-tier. Sometimes the wire itself acts like a physical doorstop.
Oh, wedging the leaflets apart.
Exactly, and directly causing the regurgitation in the first place. If a patient has a pacemaker lead, but the high-resolution imaging shows the lead is not actively impinging on the leaflets and there is clear space to maneuver, the anatomy is considered complex but treatable.
But if it's in the way.
If the lead is severely impinging the leaflets, entangling the chordae, or physically blocking the clip from grasping the tissue, it is deemed unfavorable. You cannot simply clamp a metal clip over a pacemaker wire.
That sounds disastrous.
Doing so would destroy the valve and potentially sever the electrical lead.
To synthesize all these rules, anatomical scores, and imaging requirements, the authors provide Figure 1. It's a comprehensive decision pathway flowchart specifically tailored for the Asia-Pacific region. Let's trace the patient's journey.
Yes, do it.
Step 1. You have a patient with symptomatic severe or worse tricuspid regurgitation. The immediate first question the heart team asks is, does this patient have other concurrent conditions that warrant open heart surgery anyway?
That is the crucial triage point. If the patient has severe coronary artery disease requiring a bypass, or if their aortic valve needs surgical replacement, the pathway dictates that the surgeon should perform a surgical tricuspid repair simultaneously while the chest is already open.
These are already in there.
Exactly. It is the most definitive mechanical fix. But if there is no other indication for open heart surgery, we proceed to Step 2.
Step 2. The team evaluates the anatomical scorecard. Are they suitable for T-tier? If the gap is under 10 millimeters, the pacemaker wire isn't in the way, and the jet location is favorable, the patient proceeds to get the transcatheter clip.
Green light.
But what happens if they hit an anatomical roadblock? What if the gap is 13 millimeters and their leaflets are hopelessly tethered? Step 3 asks if the patient is suitable for non-tier interventions.
If the anatomy outright rejects the edge-to-edge clip, the heart team must explore the emerging frontier of transcatheter therapies.
Like what?
This might involve enrolling the patient in trials for transcatheter tricuspid valve replacement, where an entirely new prosthetic valve is deployed via catheter to basically crush the old one out of the way.
Wow.
Alternatively, for patients in end-stage failure, they might consider caval valve implantation. This is a purely palliative procedure where valves are deployed in the vena cava to stop the regurgitant blood from destroying the liver.
Even though the tricuspid leak itself is still there.
Right, it just protects the organs. However, if the patient's anatomy or frailty makes them unsuitable for any of these advanced options, the flowchart leads to the final, sobering reality.
Which is optimizing medical therapy and integrating palliative care to manage symptoms.
Yeah. The entire algorithm is designed to aggressively treat those who can be saved, while meticulously preventing futile, dangerous interventions.
That structural framework brings us perfectly to the other side of the heart. We are crossing over from the right side to the high-pressure left side. The mitral valve.
The heavy lifter.
Transcatheter ecosystem for the mitral valve is vastly more mature, but it is currently undergoing an absolute explosion of new trial data.
The left ventricle pumps oxygenated blood to the entire body. The pressures here are immense, and treating mitral regurgitation with TEER has a much longer clinical history.
So what are the tools they're using here?
The consensus establishes the landscape by introducing the 3 dominant devices in the Asia-Pacific market. You have the highly established MitraClip, the advanced Pascal system, and the newly developed Dragonfly device.
To fully grasp the current clinical rules, we have to look at the foundational data. Historically, the entire field of MTIR was validated by the COAPT and MITRI-HAV-R trials published back in 2018.
Those were the game changers.
Yeah, those trials proved that clipping a leaky mitral valve could fundamentally alter the mortality trajectory of heart failure patients. But the 2026 consensus is built upon a wave of brand new monumental studies.
Let's get into the new data.
First up is the ReShape HF2 trial. This was a massive undertaking involving 505 patients. They took patients suffering from symptomatic heart failure with moderate to severe or severe secondary mitral regurgitation.
A very sick cohort.
Half of the patients received a MitraClip combined with guideline-directed medical therapy, while the control group received only the medical therapy. When they look at the data at the 2-year mark, what was the primary clinical takeaway?
The ReShape HF2 trial was definitive. The primary endpoint evaluated a composite of cardiovascular death and recurrent heart failure hospitalizations over 24 months.
And what did they find?
The results demonstrated a highly significant reduction in adverse events for the MitraClip group, heavily driven by a massive decrease in heart failure hospitalizations.
Which we discussed earlier, that's not just a minor inconvenience.
We have to contextualize what a heart failure hospitalization means. It is not a brief trip to the clinic. It involves a patient literally drowning in their own pulmonary fluids, requiring intensive intravenous diuretics, and suffering incremental, irreversible end organ damage with each admission.
So stopping that cycle is huge.
By mechanically reducing the regurgitation, the clip interrupts that catastrophic physiological loop. Beyond the hard survival metrics, the patients who received the clip reported vastly superior quality of life and symptomatic improvement compared to those marooned on medical therapy alone.
So ReShape-HF2 proves beyond a shadow of a doubt that the transcatheter clip beats purely pharmacological management. But it raises the ultimate surgical question.
Clip versus surgery.
Exactly. How does the transcatheter clip compare to actually sawing the chest open and letting a surgeon physically rebuild the valve? That exact question was answered by the Matterhorn trial.
I love this trial.
They took 210 patients with symptomatic severe secondary MR, all of whom were failing optimized medical therapy. They randomly assigned half to receive the MitraClip and half to undergo open-heart mitral surgery.
The Matterhorn trial provided the nuanced, head-to-head data the structural cardiology world had been waiting for. At the one-year follow-up, the transcatheter approach was proven to be non-inferior to open-heart surgery regarding a composite outcome of death, heart failure, hospitalization, reintervention, or residual moderate to severe
Non-inferior is a very specific statistical term, right? It just means it didn't fail at a higher rate than surgery.
Correct. But the true value of the Matterhorn data lies in understanding the trade-offs. The physiological reality is that open-heart surgery achieved a more complete, absolute elimination of the regurgitant leak.
Because they can see the whole valve.
Right. The surgical ring annuloplasty provides a tighter mechanical fix. However, the TEER procedure demonstrated significantly fewer early procedural complications, less major bleeding, and a vastly accelerated recovery timeline.
Which matters a lot if you're 80 years old.
Exactly. For an elderly, fragile patient, achieving a highly effective reduction in MR without the profound systemic trauma of a cardiopulmonary bypass machine is often the far superior clinical path, even if it trades a fraction of mechanical perfection for immense safety.
We also have crucial new data expanding the device options. The Class P IAD trial investigated the Pascal system. It demonstrated that in patients facing prohibitive surgical risks with degenerative NR, the Pascal device was statistically non-inferior to the established MitraClip.
It works just as well.
At the one-year mark, both devices delivered comparable clinical outcomes, comparable reductions in regurgitant volume, and similar improvements in patient symptoms. This ensures interventionalists have multiple, highly effective tools at their disposal.
Choice is always good.
And crucially for this region, we have the Dragonfly DMR trial.
The inclusion of the Dragonfly device is a pivotal moment for the Asia-Pacific consensus.
Tell me about this trial.
The Dragonfly DMR trial was a rigorous, prospective, single-arm, multi-center study involving 120 patients. It thoroughly validated the safety and efficacy of the Dragonfly device in treating degenerative mitral regurgitation, showcasing an 87.5% clinical success rate at 1 year.
That is incredibly high.
And the investigators defined clinical success with extreme rigor. The patient had to be free from all-cause mortality, free from needing any subsequent mitral valve intervention, and their regurgitation severity had to be suppressed to a grade of 2+ or less.
It really proves the technology developed within the region stands shoulder to shoulder with global standards.
No doubt.
With all this overwhelming trial data confirming the efficacy of MTEER, how does a physician sitting in a clinic actually apply it? The consensus translates this data into mitral statements 7 through 16. The most critical conceptual leap required here is understanding that the clinical rules depend entirely on why the mitral valve is leaking in the first place.
The root cause.
You must distinguish between degenerative mitral regurgitation, or DMR, and ventricular functional mitral regurgitation, FMR. Let's tackle DMR first, covered in statements 7, 8, and 9.
Degenerative mitral regurgitation is a structural failure. The physical architecture of the valve is broken. A chordae tendineae has snapped, a leaflet is severely prolapsing, or the tissue has physically degenerated.
The door is broken off its hinges.
Yes. Statement 7 establishes the primary rule. If a patient presents with severe 3 plus or greater DMR, meets the criteria for surgical intervention, but is deemed to be at high surgical risk by the heart team, they should be strongly considered for MTR.
Statement 8 expands on this, clarifying that symptomatic, high-risk 3+ DMR patients should be evaluated for a transcatheter clip, regardless of whether their left ventricular ejection fraction, which is the metric of their heart's pumping power, is reduced or preserved.
If the mechanical door is broken and they cannot survive open heart surgery, you clip it.
But Statement 9 wades into much murkier waters. It addresses the asymptomatic patient.
Always a tricky conversation.
As a patient, if I am sitting in my cardiologist's office, breathing fine, walking fine, and feeling completely normal, why would a doctor recommend threading a catheter into my heart to implant a metal clip?
It seems counterintuitive.
Statement 9 says MTR may be considered for asymptomatic high-risk patients, but only if they trip very specific clinical alarms. What are those triggers, and why do they override how the patient feels?
Well, a patient's subjective feeling of wellness is a terrible metric for evaluating chronic regurgitation.
Really?
Yeah. The human body possesses extraordinary compensatory mechanisms. Your heart will physically remodel itself, dilating and straining, to maintain output and mask the symptoms of a severe leak for years.
So you feel fine, but your heart is secretly dying.
Exactly. Beneath the surface, irreversible myocardial damage is occurring. The consensus identifies 4 objective red flags indicating that the compensatory mechanisms are failing. First, if the left ventricular ejection fraction drops to 60% or below.
I really want to highlight the physics of that 60% threshold. Because in a normal, healthy heart, an ejection fraction of 60% is considered fantastic.
It's totally normal.
So why is it a massive red flag for someone with a broken mitral valve?
Because in a heart with a severely leaky mitral valve, the ejection fraction is a biological lie.
A lie. How?
Blood behaves like any fluid. It takes the path of least resistance. When the left ventricle squeezes, it is supposed to push all the blood out through the high-pressure aortic valve to the body. But if the mitral valve is broken, a massive volume of blood shoots backward into the low-pressure left atrium.
Because it's easier.
Right. So while the ventricle might technically be ejecting 60% of its volume, half of that volume is going the wrong way.
Oh, wow.
If an MR patient's overall ejection fraction drops to 60%, their true forward-moving cardiac output is catastrophically low. The heart muscle is failing.
That makes perfect sense.
Okay.
The second trigger is left ventricular dilation, specifically if the end systolic diameter stretches to 40 millimeters or more.
The heart is ballooning out.
The third trigger is the onset of new atrial fibrillation, signaling that the electrical pathways of the heart are stretching and short-circuiting under the massive fluid pressure. And the final trigger is pulmonary hypertension, marked by a resting pulmonary artery systolic pressure of 50 millimeters of mercury or higher.
If a doctor sees any of these structural failures on an echo, they intervene immediately.
Regardless of whether the patient feels fine.
Precisely. You intervene to preserve the remaining myocardium before the damage becomes permanent.
So that covers degenerative MR, where the valve itself is broken. Now we must pivot to ventricular functional mitral regurgitation, addressed in statements 10 to 14.
FMR, a completely different beast.
In FMR, the valve leaflets are completely normal. There is no physical damage to the swinging doors. However, the left ventricle itself has ballooned, dilated, and stretched out due to severe heart failure or a massive heart attack.
The frame of the door is warped.
Exactly. Because the muscular frame holding the valve is stretching outward, the perfectly healthy leaflets are physically pulled apart. They can no longer meet in the center.
This physiological distinction is paramount. Functional MR is fundamentally a disease of the ventricle, not the valve.
So you treat the ventricle.
Therefore, you cannot simply rush to clip the valve. You must attempt to heal the ventricle first. Statement 10 lays down an unbreakable rule. MTR should only be considered for symptomatic ventricular FMR patients if they are already receiving fully optimized, guideline-directed medical therapy.
Meads first again.
Always. This includes the implementation of cardiac resynchronization therapy or CRTD devices if they meet the electrical indications. You must deploy every pharmacological and electrical tool available to shrink the ventricle back to its normal size before you even consider a mechanical clip.
Statement 11 introduces a critical procedural delay for a specific subset of these patients, those with ischemic FMR. This means the ventricle stretched out because the patient has severe coronary artery disease. The heart muscle is starving for oxygen.
It's dying from lack of blood.
The consensus strictly mandates that doctors must evaluate the coronary anatomy and address the ischemia before performing M-TEER. If the patient requires percutaneous coronary intervention, putting stents into the blocked arteries, they must undergo stage therapy. They get the stents, and then they wait.
They wait.
Why not fix the blocked arteries and clip the leaky valve during the exact same procedure?
It comes back to the root cause of the ventricular dilation. If the mitral valve is only leaking because the underlying heart muscle is starving for oxygen and failing to contract, and you successfully stent the artery to restore that blood flow, the myocardium might actually recover.
It can heal itself.
The ventricle can undergo reverse remodeling. It shrinks back down, the papillary muscles realign, and the healthy mitral leaflets suddenly regain the ability to cope perfectly. The regurgitation cures itself.
That is incredible.
If you prematurely clip the valve on the same day you place the stent, you subject the patient to an unnecessary structural intervention. You fix the plumbing, optimize the medical therapy, and then, as statements 12 and 14 vehemently emphasize, you closely monitor the patient clinically and echocardiographically every 3 to 6 months.
Just to see if the meds and stents worked.
Exactly. If, and only if, they exhibit persistent severe 3+ FMR after the ventricle has had time to heal, Statement 13 dictates they should then be referred to the heart team for M-TEER evaluation.
The final two rules for the left side address the outliers. Statement 15 covers atrial FMR, a uniquely challenging condition where the regurgitation is caused by the extreme dilation of the left atrium and the mitral annulus, almost exclusively driven by long-standing chronic atrial fibrillation.
A very specific subset of patients.
The rule here dictates mandatory consultation with an electrophysiologist, highlighting the need to manage the electrical chaos before addressing the mechanical leak. And Statement 16 acts as the procedural safety net for rare, unclassified scenarios, stating these unique cases must be evaluated individually by the heart team and ideally enrolled in clinical registries to advance the science.
It is the panel's formal acknowledgement that human biology will always present anatomical permutations that defy rigid guidelines. It ensures that innovation continues safely within the bounds of peer-reviewed registries.
Which perfectly transitions us into Segment 7, evaluating the physical reality of the mitral valve once the imaging catheter is deployed. Table 2 outlines the mitral anatomical considerations, defining what makes a mitral valve favorable or completely off-limits for a transcatheter clip.
The second scorecard.
A favorable anatomy requires a mitral valve area greater than 4.0 square centimeters. The operator needs a massive, wide-open space to safely maneuver and deploy the clip without inadvertently blocking the forward flow of blood. But the unfavorable section is where the absolute hard stops exist.
The unfavorable criteria are the red lines of structural cardiology.
First is severe mitral annular calcification, or MAC, and severely calcified leaflets.
The entire mechanism of an edge-to-edge clip relies on grasping soft, pliable, flexible leaflet tissue and pinching it together.
Like pinching fabric.
Exactly. If the disease process has turned the leaflets into rigid, rock-hard sheets of calcium, the mechanical grippers of the clip cannot penetrate or hold the tissue.
So just slip off.
Attempting to force a clip onto severe calcium will inevitably result in the clip losing its grasp, or worse, physically tearing the brittle leaflet, instantly inducing catastrophic regurgitation.
Table 2 also lists mitral valve clefts, which is a literal physical split or tear within the leaflet tissue itself is highly unfavorable. But the most logical roadblock is moderate to severe mitral stenosis, defined as a valve area of 2.0 square centimeters or less.
That's a very tight doorway.
Right. If the doorway is already swollen, scarred, and critically narrowed, deploying a bulky metal clip directly in the center of that tiny opening is going to cause a massive blockage, right?
Exactly. You might successfully eliminate the backward regurgitation, but you would instantly induce severe, potentially fatal mitral stenosis. The forward flow of blood would be completely choked off.
You trade one lethal hemodynamic problem for another.
Other absolute contraindications include the presence of a left atrial thrombus or a left atrial appendage thrombus.
A blood clot.
If the transesophageal echo reveals a blood clot lurking in the chamber above the valve, introducing a massive transeptal delivery catheter into that space carries an unacceptable risk of dislodging the clot, sending it directly into the cerebral circulation and causing a massive stroke.
You cannot risk that.
Finally, active infective endocarditis is an absolute hard stop. If there is a raging bacterial infection actively devouring the valve leaflets, you cannot implant permanent foreign hardware into that infected field. The bacteria will instantly colonize the metal device, rendering the infection untreatable.
To ensure no physician skips these crucial steps, the consensus provides Figure 2, an uncompromising management flowchart specifically designed for ventricular FMR. It forces a rigorous, step-by-step evaluation.
It's a checklist for safety.
Box 1 demands the evaluation of coronary anatomy and revascularization if ischemia is present. Box 2 mandates that the heart failure specialist completely optimizes medical therapy and CRTD devices.
Like we discussed.
Box 3 dictates that only if the patient has persistent severe FMR after exhaustive medical management, they undergo a rigorous anatomical reevaluation using both key TE and TOE. Only after clearing all those biological hurdles does Box 4 allow referral to the heart team for tier consideration.
We really must emphasize the philosophical purpose of this flowchart. Interventional cardiologists are highly trained, action-oriented specialists. Their instinct is to intervene and fix the mechanical problem.
They want to operate.
Right. This algorithm is designed as a deliberate clinical speed bump. It forces the entire medical system to slow down and guarantee that the patient's biological foundation is as optimized and stable as possible before anyone attempts a mechanical transcatheter fix. It is the ultimate safeguard against futile interventions.
As we zoom out from the microscopic leaflet tissue and the dense clinical trial data, we have to look at the broader human element of practicing medicine in the Asia-Pacific region. Because despite the brilliance of these transcatheter devices, the consensus document makes it abundantly clear that the true hero of this story is not the interventionalist holding the catheter.
No, it's not.
The hero is the general cardiologist.
The highly specialized structural operators can only save the patients who actually make it to their catheterization table. The general cardiologist, or the internal medicine physician operating in a remote regional clinic, is the absolute vanguard.
They are on the front lines.
They are the ones responsible for the early acoustic detection of the murmur. They are the ones painstakingly adjusting the background medical therapy month after month. They are the ones monitoring the serial echocardiograms and tracking the cardiac biomarkers like NT-proBNP to catch the subtle deterioration of the right or left ventricle.
Because timing is everything.
Their clinical acumen determines whether a patient is referred to a comprehensive valve center while the heart muscle is still salvageable, or if the referral happens too late, after irreversible end organ damage has set in.
And their job doesn't end when the patient gets the clip. They take the patient back. They handle the complex post-intervention monitoring, the endless medication adjustments, and the long-term survival strategy.
The authors conclude the consensus document with a stark, deeply honest warning regarding the reality of the Asia-Pacific region.
What's the warning?
They state explicitly that these guidelines are designed to augment, never to replace, localized clinical judgment. A physician operating in a developing nation will read these exact same guidelines as a physician in a heavily funded, hyper-modern academic center. They will both understand the gold standard of care.
But they must navigate vastly divergent realities.
Right. They have to account for their specific center's resources. Do they have a highly competent, experienced TOE echocardiographer available 24 hours a day to guide these complex procedures? What is their access to the latest generation of transcatheter devices?
Not every hospital has every clip.
And vitally, they must navigate the profound cultural factors and patient preferences regarding invasive procedures, family care structures, and long-term medical compliance across diverse Asian populations.
If the disease burden is accelerating and the regional disparities are so vast, what is the path forward? How does the medical community bridge that gap?
The consensus points toward massive infrastructural development. It calls for the rapid expansion of regional clinical registries to meticulously track how these transcatheter devices perform specifically within diverse Asian populations over time.
To get more tailored data.
It demands the creation of highly structured hub-and-spoke referral networks, ensuring that a patient diagnosed in a rural clinic has a clear, established, and frictionless pathway to reach a comprehensive structural heart center.
A pipeline to care?
And it emphasizes the absolute necessity of collaborative cross-border training programs to elevate the imaging and interventional expertise across the entire Asia-Pacific landscape. The goal is to ensure that access to these life-saving, minimally invasive technologies becomes an equitable standard of care rather than a luxury reserved for those in major metropolitan hubs.
It is an incredibly dense, deeply necessary document that paints a picture of a cardiovascular field evolving at breakneck speed. Which leaves me with a lingering thought for you, the listener, to ponder as we close out this deep dive.
It's a big question.
We have spent the last hour dissecting the mitral clip, the Pascal, the Dragonfly transcatheter devices that are becoming increasingly microscopic, steerable, and mechanically advanced. As this transcatheter technology continues to aggressively push the boundaries of what is possible without ever opening the chest, will the open-heart valve surgeries of today eventually become a purely historical procedure?
It's fascinating to think about.
Are we approaching a future where medical students only read about sternotomies and cardiopulmonary bypass machines in textbooks? Or is the human heart so infinitely complex and our anatomical variations so wild that there will always be a biological curveball, a massive gap, an impossibly calcified leaflet, a tethered chordae that a transcatheter clip simply cannot solve, ensuring that the cardiac surgeon's scalpel remains a necessary, undeniable reality of human medicine?
It is the defining question that will drive the evolution of structural cardiology for the next decade.
Thank you for watching The Funnel Effect.